Hello everyone, welcome once again to Words Made Easy. My name is Dr. Beston Wheeler, and today we're going to dive into yet another interesting topic, which is Prom and Pprom, okay, which is premature rupture of membranes and preterm premature rupture of membranes, also known as pre-labor rupture of membranes and preterm pre-labor rupture of membranes. Okay, so if you haven't subscribed to my channel, please subscribe. Okay, hit the like button, share, so that you are able to view more content, okay, that we're producing. Produce awesome content. There's already a video on cervical cancer. Okay, there's a video also on how to administer magnesium sulfate in severe preeclampsia. Please go and watch those videos, and please stay tuned for more content. With that being said, let's begin. Let's talk about Prom and Pprom. So what do we mean when we talk about this? So Prom and Pprom are actually found in what you call, it's actually an abnormal rupture of membranes. So the abnormal rupture of membranes, this is where there's a rupture of membranes before the onset of labor. So we know that the membranes are supposed to rupture when labor begins. But if membrane rupture occurs before the onset, if membrane rupture occurs before labor begins, then we call it abnormal rupture of membranes. And this abnormal rupture of membranes can either be premature or pre-labor rupture of membranes, okay, which is Prom, or it can be preterm pre-labor rupture of membranes, which we also call Pprom. Okay, so these are the two that we have. So membranes, ideally, in the normal setup, membranes are supposed to rupture, okay, when labor has begun. So if these membranes rupture before labor starts, that is called an abnormal rupture of membranes, and it can be Prom or Pprom, okay? It can be Prom or Pprom, okay? Now, Prom happens when the membranes rupture occurs at or after 37 weeks gestation age, but before labor. Okay, so if it is occurring at 37 weeks of gestation or after 37 weeks of gestation, but before labor starts, that is called Prom. It's called pre-labor because it's occurring before labor. So it's called pre-labor rupture of membranes or premature rupture of membranes. Then we have what we call Pprom. Okay, this one, it's preterm. There's a term P. The other P is called preterm. It's preterm. This P is for preterm. So this is preterm premature rupture of membranes or preterm pre-labor rupture of membranes. It means that this premature rupture of membranes is occurring before term, and term starts at 37 weeks. So 37 weeks to 42, that's term. Then if it is occurring before 37 weeks, if it happens before term, which is before 37 weeks, then we have what we call Pprom. Okay, so we have two. We have Prom. Prom is if this rupture of membrane, this premature rupture of membranes happens at 37 weeks, but before labor onset. And then Pprom is when this rupture of membranes happens before term, which is before 37 completed weeks of gestation. The incidence of this condition is about 4 to 18% of pregnancies. Okay, so it's quite common. Okay, so this simply means that if you are to get about 100 pregnancies, you find about 4 to 18 mothers are going to come in with this particular condition. Okay, and it's responsible for about 50% of preterm deliveries. Okay, 50% of preterm deliveries, because we know that mostly when the membranes rupture, most women within 24 hours, they will go into labor and they will deliver. Okay, and 10% of perinatal mortality. So it's quite common. It's a problem. Okay, so it's quite a common cause of perinatal mortality, especially in our setup. What are the causes of Prom? We've understood to say This is a serious condition. This is a very common condition. But what are the causes of this abnormal rupture of membranes? What are the causes? So the causes could include infections. So infections, for example, chorioamnionitis. Okay, this is infection. Chorio means placenta. Amnion means the amniotic membranes. So inflammation of the placenta and membranes, including the amniotic fluid inside. Okay, this in itself, this is, you have an infection, mostly bacterial, that is causing inflammation within the placenta, the membranes as well. STIs, okay, sexually transmitted diseases. Cervicitis cervicitis can even be part of a sexually transmitted disease. Okay, where you have an infection causing inflammation of the cervix. Okay, so note that these infections, okay, most of them are bacterial, most of them being bacterial. They can produce what you call proteases and phospholipases. So once they produce these substances are able to weaken the membranes. Okay, so once you weaken the membranes cannot hold the force anymore, and so they can rupture. Okay, these bacteria as well and infections that you find here can also stimulate an immune response, and that immune response can lead to inflammation, as we know, inflammation and release of prostaglandins as well, and we know that this can lead to rupture of membranes. Okay, the second one is cervical and uterine factors. So we have certain things that can, anything that is affecting the cervix, okay, like cervical incompetence. Okay, so we have cervical incompetence. You know that cervical incompetence is where the cervix is not so strong. Okay, I would say the cervix is not so strong, such that as the pregnancy proceeds, as the pregnancy becomes heavy and proceeds, you find that the cervix will open on its own, and then they will have an abortion. They are usually the most common cause of second trimester abortions. Now, in that setup, when the cervix opens on its own, the membranes may be forced to rupture, and then you have prom happening. So you can have uterine overdistension due to polyhydramnios and multiple pregnancy or multiple gestation. You know that these are going to put excessive stretch on the membranes, and then it can lead to rupture of these membranes. Polyhydramnios is basically an increase in the amniotic fluid, more excessive increase in the amniotic fluid. You know that the normal amniotic fluid is 5 to 25, okay, 5 to 25 centimeters. That is on the amniotic fluid index. So above 25 centimeters, you will find that this is polyhydramnios, and that puts you have excessive amounts of amniotic fluid, and that can put more stretch on the membranes, and then they can rupture. Same applies to multiple gestation. You also have placenta and membrane problems. So these placenta and membrane problems can be placenta previa, rupture placenta, or in a situation where you have weak and defective membranes. So if the membranes are weak or they are defective, already they can't hold the stretch and the shear pressure that is that's going to be produced by the baby inside and the amniotic fluid. Okay, so they will rupture. Okay, and then this will lead to prom or pprom. Okay, obstetric interventions as well and trauma. For example, amniocentesis. Amniocentesis is a procedure where you want to sample the amniotic fluid. So you push in you are pushing in a needle, okay, and then you want to sample from that amniotic fluid. And that procedure itself is going to cause trauma to the membranes, and that can lead to membrane rupture. Okay, cervical sacrilege complications. In a case in a patient who comes with cervical incompetence, what we do is that we put what we call cervical. We do a procedure called cervical sacrilege, and then we want to put a sacrilege there where we tie the cervix. During that procedure, you can accidentally injure or rupture the membranes, and then that can lead to prom. Trauma due to physical violence or iatrogenic causes. Okay, so physical violence in the abdomen, physical violence in the pelvis, that can force the membranes to rupture, and that trauma can actually lead to prom or pprom. We have maternal factors, for example, smoking. So if this mother is smoking, you know that smoking weakens the membranes. Poor nutrition as well weaken the membrane. Low BMI, okay, a low BMI, this is someone who is underweight, malnourished, the membranes will be weak. And of course, history of prom or Pprom. Okay, so if they have a history of Prom or Pprom, because whatever could have caused the Prom in the previous pregnancy or the Pprom in the previous pregnancy could be the same thing that may lead to a Prom or Pprom in this particular pregnancy that they have now. So those are the causes of abnormal rupture of membranes. Okay, so those are the causes that we have of abnormal rupture of membranes. Let's talk about the clinical features. So what are these clinical features? So this patient will present with a gush of fluid. Okay, there will be a gush of fluid, then leakage of fluid. This is the main presentation. Okay, so they will tell you that, no, doctor, I had a gush of fluid, okay, or they suddenly notice some fluid coming out from the vagina, okay, and then after that, that sudden gush of fluid may be followed by continuous leakage of this fluid. That's the main presentation that they will tell you. They may present with vaginal discharge in cases where they had an infection. Okay, so this can come before or after the rupture of the membranes. Okay, so they can present with that vaginal discharge. They say they had an infection, and because of that infection, it weakens the membrane, and then they'll present with this discharge, okay, as well. Vaginal bleeding as well, okay, this may mix with amniotic fluid. In some cases, you'll find that when the membranes rupture, because of that sudden gush of fluids, there will be sudden decompression. So that decompression pressure, remember the fluid is rushing out of this fluid is rushing out of the uterus, okay, because the membranes have ruptured. So that decompression pressure can pull the placenta, and it can cause abruption of the placenta. And you may end up with a case where you have bleeding as well accompanying this case. There's also other cases of, for example, vasa previa. When you have vasa previa, the membranes rupture, that rupture and sudden decompression and movement of fluid may cause the blood vessels that were not lying within the membranes in the placenta, may cause those blood vessels to begin to bleed, okay, and you end up with bleeding as well, okay. Pelvic pressure, so they may feel some pelvic pressure as well as a symptom. The most common presentation is they will tell you that they had a sudden gush of fluid, and then they are now leaking fluid, leakage of fluid. Others will mention it to say draining, okay, they are draining, okay. That's one term that you may encounter as you practice. So not that there should be no uterine contractions, because if this patient comes in, the membranes have ruptured, and then you have uterine contractions and some cervical changes, then you're not dealing with Prom or Pprom, but you're dealing with a case of labor. So this woman would have been in labor. Remember, labor, yeah, you are going to have progressive uterine contractions, okay, that will be increasing in intensity and in frequency and duration as well, okay, as well as the intensity, and that is coupled with cervical changes, okay, which could be dilatation and effacement, okay, effacement and dilatation. That is labor. So if this woman comes in with contractions and cervical changes, then you are dealing with labor and not Prom or Pprom. That's why when you assess this woman, you need to establish that they are not in labor, but they've just presented with Prom or Pprom. How do we diagnose this condition? So on history, the woman will give you a history of a sudden gush of fluid. Just as we said, they all have a sudden gush of fluid, and this may be followed by continuous leakage of the fluids. And when you get this history, what do you do? When you get this history from a woman, do not perform a vaginal examination. I'll repeat. Once you get this history of a sudden gush of fluid from a woman or leaking of fluids from this pregnant woman, do not perform a VE. Don't stick your fingers in that woman's vagina for examination. Do not perform a VE in that particular case. So what do you do then? When you get this history, you need to perform what you call a sterile speculum vaginal examination. Now you note that this is sterile, and they are using speculum to do a vaginal examination. So it's sterile procedure. Why? Remember that what protects the baby, what protects the fetus, okay, during pregnancy is that this fetus is also protected by these membranes. These membranes act as a protective barrier so that whatever is down there in the vagina, whatever is down there in the cervix, cannot ascend to go and affect the baby. And because the membranes have ruptured, you've removed that physiological and anatomical barrier that is between the external environment and the baby. And because you've removed that barrier, you are risking this. There's a high risk of infection in the fetus. Okay, that's why when you perform your vaginal examination, you stick your fingers there. If you do that, you are likely to introduce infections, and that infection that you introduced is straight away going to go and affect the placenta, the membranes, and the baby, and you end up with chorioamnionitis, okay, which is fetal to the baby, which is fetal to the mother as well. So do not perform a VE when you see a woman comes in with sudden gush of fluid and draining of fluid, amniotic fluid. When you get this history, what you need to do, you perform a sterile speculum examination. This is performed under sterile conditions, okay? And once you perform a sterile speculum examination, this is where you get the casco speculum, you push it in. This is something that is sterile. You push it into the vagina, you swab the vagina, you push it in, and then you open. And what you see when you open, it gives you a clear view of the cervix and the vagina. And once you see what are the findings on sterile speculum examination, you are going to see pulling of fluids into the posterior fornix of the vagina. So in the posterior fornix of the vagina, you will see fluid that is pulling. What is that fluid? That is amniotic fluid that is leaking. Fluid coming out of the cervical os may be seen as well, because you'll be able to visualize the external os of the cervix, and you'll be able to see the fluid coming out. What maneuvers do? You can ask the patient to cough. Okay, when the patient coughs, it's like they perform a Valsalva maneuver. Okay, let the patient cough, they increase intra-abdominal pressure, that is going to force the fluid to come out. And once they cough, you may be able to see some fluid trickling from the external os of the cervix. Or you can apply some fundal pressure. Okay, you apply some fundal pressure on the fundus of the uterus, that may force some fluid out, and you may be able to see the amniotic fluid. After you do this, you then collect the fluid that is coming out and perform the following tests. Number one, you can perform what we call the nitrazine test. So what is the nitrazine test? Okay, what is the nitrazine test? The nitrazine test is where you're going to get this amniotic fluid and put it on a nitrazine paper. This is a pH sensitive paper. Okay, now we must understand one concept. The pH of the vagina is normally acidic because of the presence of a bacteria that we call Lactobacilli acidophilus. That bacteria is able to produce acid in that particular environment of the vagina, causing it to be acidic to prevent infections. Now the pH of the amniotic fluid, the pH of the vagina is around 4.5, which is acidic. The pH of the amniotic fluid is around 7.0 to 7.7, somewhere there. Now this pH is alkaline. Okay, now when you look at this nitrazine paper, it is able to detect, it's a pH sensitive paper. If it is alkaline, if it's an acidic environment, it becomes yellow. If you are dealing with an alkaline environment, it becomes blue. Okay, it becomes blue, meaning the pH is above 6. So because of the presence of amniotic fluid within the vagina, if that fluid is not from the vagina but it's amniotic fluid coming in, when you collect it and put it on a pH sensitive paper, you are going to find that it is going to turn color into blue, because the pH of the amniotic fluid that you've taken from the vagina is alkaline. That shows you that in this acidic environment of the vagina, why is the pH becoming alkaline? Because there's amniotic fluid that has come in, and you've taken the amniotic fluid, and that helps you to make a diagnosis. However, we must know that there are certain things that can lead to a false positive. For example, if there's presence of blood, if there's presence of semen, semen is alkaline. Okay, blood is not acidic. Okay, or if you have bacterial vaginosis, in bacterial vaginosis, it's in an alkaline environment, isn't it? Because it's mostly caused by people that love to douche, especially if you douche a lot. Okay, you wash the inside of the vagina, you wash it with this detergent, or you wash it, it's not supposed to be washed. When you wash, you find that washing itself is going to remove or clear out the Lactobacilli acidophilus, okay, the normal flora, and that is going to cause a pH to increase with colonization of other bacteria, okay, that are not supposed to be there. So this is bacterial vaginosis. that you develop there. So the pH in these cases may show out to be alkaline. So these are things you should put into your mind. They'll give you a false positive. You may think, the nitrogen test is positive because the pH paper has turned blue. Okay, you must be able to know that if there's blood, if there's semen, or the woman has bacterial vaginosis, the pH sensitive paper will turn blue because that environment will become alkaline. However, we use this test and it's very good. There's also what you call the microscopic fanning test. So microscopic fanning test is that when you get this amniotic fluid that you see that collected, that has collected in the posterior fornix of the vagina, get it, put it on a slide, you smear it on a slide, okay, you smear it on a slide, and then it dries, and then you observe using a microscope. When you use a microscope and visualize this slide, you are going to find that this amniotic fluid is going to crystallize because of the presence of sodium chloride, proteins, and other carbohydrates within the amniotic fluid. So because of those things being present, the amniotic fluid itself crystallizes and it forms what you call a fanning pattern, and that is what we call the fanning test. So when you see a fanning pattern, then you know that I'm dealing with amniotic fluids. Again, do not perform a vaginal examination. Do not do a VA. This is what I'm talking about. So you have the baby here. So this is the fetus, and then you have the uterus there. You have the placenta. Okay, this is the placenta bed. Okay, you have the placenta. This is the umbilical cord. Okay, and this is the baby encephalic. And you have the amniotic fluid here in blue, and then you have the membranes right there in white. And these membranes, you can see that these membranes have ruptured, and this amniotic fluid is coming out. And this is what you call prom or rather Pprom. Okay, you have, this is the coscal speculum. Okay, this is the coscal speculum. This is what you use, and this is the cervix. This is how it will sit when you push it inside the vagina, and this is what you are going to see. So down there, that is where the posterior fornix of the vagina is, and you'll see fluids collected down there. Okay, and then on this is the external os, you see some fluids that may be coming out. This is a picture showing you the fanning pattern. So this is a microscopic fanning test, okay, that has been done, and this is a fanning pattern. So amniotic fluid will crystallize and it will show you things like this. This is what you call a fanning pattern. This is what you call a fanning pattern. Okay, this is a fanning pattern. The other part of the diagnosis is the OBS ultrasound. So you can order for an ultrasound scan. Okay, so it will give you information on the following. Once you do an ultrasound scan, an OBS ultrasound, it will give you information on the fetal well-being. How is the fetus doing? Okay, fetal well-being. It will give you information on the level of amniotic fluid, which in most cases may be reduced. Okay, why? Because this fluid is leaking. There's leakage of fluid, and so you find that the amniotic fluid levels will reduce. Okay, but you must be careful in women who have polyhydramnios, because these women that have polyhydramnios, the amniotic fluid levels may remain the same. Remember, we're saying polyhydramnios is where you have excessive amniotic fluid. So which means that in this particular women where you have excessive amniotic fluid, even when they are draining, when you are seeing them for the first time, you may actually think this amniotic fluid level is normal. But then they had excessive and it has just drained and went back to normal. You can do vaginal swab for microscopic culture and sensitivity if you are suspecting that there may be an infection. Full blood count, okay, FBC-DC, full blood count and differential count, okay, it's also important to give you white cell count may be elevated in cases of infections. Lecithin sphingomyelin ratio. So this one helps you to detect if the lungs of the baby are matured. Remember, we said when the membranes rupture prematurely, okay, especially in preterm, premature rupture of membrane before term, okay, the lungs of the baby may have not matured and ready for them to be delivered. Okay, so when you do a lecithin sphingomyelin ratio, it shows you whether the lungs have matured. So if you find that the ratio is greater or equal to 2 to 1, then the lungs are matured. However, you say the lungs are immature if it's less than 1.5 to 1. The other test you can do to check for lung maturity is what you call the phosphatidylglycerol test. Okay, and this test also can be helpful. You can do your ESR and CRP. This is the erythrocyte sedimentation rate and C-reactive proteins. These are active phase reactants, so they'll show you that there may be an inflammatory process going on. What are the complications of Prom and Pprom? So we divide them into fetal complications and maternal complications. So on the fetal side, on the fetus, what are the complications? So it can be fetal and neonatal infections. So you remember that barrier of that barrier against infection has been breached, and so these fetus can easily develop an infection. And this is something you can see when they are born as neonate also, because they may end up with sepsis, they may end up with meningitis, they may end up with bronchopneumonia because of those infections that they may have, because of the environment may have had, they may have acquired some infection in the process. Cord prolapse as well. Remember when the membranes rupture suddenly, okay, that gush of fluid coming out can carry the cord together, and that cord can prolapse, okay, which becomes now an emergency. You need to go and deliver quickly. Malpresentations as well. The fetus can change position after membranes rupture. Prematurity, because the pregnancy may not be carried up to term, and this baby may be born prematurely. Then you can also have patent ductus arteriosus, PDA, which may also occur because of premature delivery. Okay, so the ductus arteriosus, which was supposed to close, may not have closed by the time the baby is delivered. Maternal complications would include infections like chorioamnionitis and endometritis, because of that breach in the barrier for infections. You can have sepsis. Okay, the mother can develop sepsis. They can develop disseminated intravascular coagulation, because this particular endotoxins, okay, these toxins that are produced by these infections may go and cause damage to blood vessels, and then consumptive coagulopathy, which is DIC. You can have abruptio placenta as well occurring because of that sudden decompression. It pulls the placenta together, and the placenta may detach from where it is attaching in the uterus. What are the treatments? How do we treat this? So you need to estimate the gestational age. Once you suspect Prom or Pprom, estimate the gestational age, okay? Because the management is going to depend on what gestational age this patient is at. So you make sure you estimate the gestational age. Establish if the woman is in labor or not. And if the woman is in labor, you need to deliver after a course of antibiotics. So put them on antibiotics and then deliver them if they are already in labor. Okay? Assess for the complications like chorioamnionitis, vaginal bleeding, or complications that may occur, because this will help you to determine the line of management that you are going to follow. Okay? Because you also need to cater for these particular complications that have occurred. You need to admit the woman, okay? Admit this woman. There are few exceptions where a woman has got Prom or Pprom, where you may need to treat them as outpatients. There are few exceptions, but otherwise you need to admit them. Unless this woman is someone who understands the dangers, it's someone who is compliant with the measures you are going to give them, it's someone who maybe stays near the hospital such that if they develop anything, they can easily report to the hospital. So those are people that you can consider to discharge. If they are able to take care of themselves properly, they can take care of themselves properly, and they are very conscious about the health and can easily detect a problem and can report fast to the hospital once it occurs. Limitation of physical activity. So activity should be limited, okay? They should be on bed rest and also pelvic rest, okay? No sex for that period. Consider thromboprophylaxis. You will give them prophylaxis for DVT. You can consider that, because this patient may be in the hospital for some time. Immobility, and pregnancy is a hypercoagulable state, and plus if you add on the immobility that they may have because they will limit the physical activity, that gives the stasis, okay? The vicious stride of DVT. So that itself, the immobility and also the pregnancy itself, puts them at the risk of developing a deep vein thrombosis. You may consider thromboprophylaxis. Maternal monitoring, very important. Pad check and pad count, okay? How many pads are they changing and how soaked are they with the amniotic fluid? Gives you an idea of how much they are losing. signs of infection. So monitor the maternal temperature and the maternal pulse rate. Now, the first thing that will show you that they've developed an infection after prom is the pulse. The pulse will increase even before the temperature does. So monitor the temperature, monitor the pulse of the mother regularly. Fetal monitoring as well, you monitor the fetal heart sounds, okay? It will show you if this fetus is going into distress or not. So fetal heart rate may increase in chorioamnionitis. So let's talk about how you treat now prom at or after 37 weeks. So when you have prom at or after 37 weeks, how do we treat these patients? So these patients are supposed to be put on antibiotics. Now I'll tell you, usually we use erythromycin in our setup, but there are more antibiotics like amoxicillin, it can be used. But mostly we use erythromycin 500 milligrams. So give them antibiotics. You need to inform NICU, neonatal intensive care unit, okay, because this baby, in case you may need to admit this baby to NICU. And 80% of these women will go into labor within 24 hours, okay, and near to 10% may go after the next 24 hours into labor. Okay, that's why the management can be active management or expectant management. Okay, expectant management is based on the fact that these women, 80%, most of them, after the membranes have ruptured, they may go into labor within 24 hours, so you remain expectant. But however, active management should be done if the cervix is ripened. If this prom has happened at 37 weeks, the baby is already mature, and the membranes are ruptured already, okay, you may need to, if the cervix is ripened, you may need to induce labor with oxytocin if there are no contraindications for vaginal delivery. But if there are contraindications for vaginal delivery, these are patients that you consider that are supposed to take for cesarean section delivery. But if vaginal delivery is not contraindicated, cervix is adequate and ripened, you may just need to augment to induce labor with oxytocin and then deliver this woman. The expectant management is done if the cervix is not ripened. If the cervix is not ripened, you may wait for 24 hours to allow for ripening to occur, okay, within that 24 hours. And then spontaneous labor onset may occur in that particular case. But if this fails, okay, as long as there's no contraindication to vaginal delivery, you may induce labor, okay, where you do your Bishop's score and then you manage accordingly. If you have Pprom at 34 to 36 weeks, what do? You admit this woman, okay, you cancel them, admit them, and give them antibiotics. The antibiotics that we give is erythromycin, as I said. It's given at 500 milligrams per oral, twice daily, for as long as these patients are admitted. So you put them on these antibiotics. Then you give steroids, okay, then you also give steroids at 34 to 36 weeks. Now, this only applies to our setup, okay, in Zambia. Mostly, you may need to give steroids in our setup. Why? Because in a lot of cases, we are not sure of the gestational age. But however, the standard is that at 34 weeks, we know that lung maturation would have taken place, and there would be no need for us to give steroids. But the reason why we opt to give steroids at 34 to 36 weeks, even at 34 to 36 weeks, is because most of the pregnancies, most of our women, our clients that we see, most of them you find that they don't plan for pregnancies. There are very few that plan to have a pregnancy. So they may not even be sure of their gestational age. And because we're not sure of the gestational age, you may need to, of their LMPs and GA, okay? Even at 34 to 36 weeks, you may consider to give these steroids. So what steroid? The steroid of choice we give is dexamethasone, 6 milligrams IM intramuscularly, twice daily for 2 days. Okay, this is most commonly used in our setup. But the first line of management steroid is betamethasone. It's the first line. But in our setup, usually we use dexamethasone, 6 milligrams IMBD for 2 days. Expectant management here can be employed. If labor doesn't start within 24 to 48 hours, then you may need to induce with oxytocin, okay, in this case. When you induce only induce if at all there's no contraindication to vaginal delivery. So you need to do your Bishop score, okay? If your score is poor, you may need to ripen the cervix first and then ripen the cervix, and then you proceed. Induce first with so you need misoprostol to ripen the cervix, and then oxytocin as well. Okay, but if at all you have a situation where the cervix is ripened as well, okay, labor doesn't start 24 to 48 hours, but the cervix is ripened, you just induce with oxytocin. But there shouldn't be a contraindication to vaginal delivery. If the pelvis is not adequate, you take forceps. Okay, if there's a contraindication to vaginal delivery, you take forceps. If this prom is happening at 28 to 34 weeks, okay, now the 28 again, you may find in other literature they will tell you 24 to 34 weeks because of the age of viability varying in different setups. But in our setup, the age of viability is 28 weeks. Okay, so 28 to 34 weeks. Pprom at 28 to 34 weeks. What do? Admit the woman, okay? You admit this woman, bed rest for this woman. You give them antibiotics just as before, okay, which is erythromycin, 500 milligrams per oral, BD, okay? Then steroids for lung maturations, the dexamethasone that we talked about, okay? The 6 milligrams BD, dexamethasone. If contractions start, you can give tocolytics at this stage, okay? Tocolytics like magnesium sulfate. Magnesium sulfate has also been shown to be neuroprotective in these particular babies, okay? So tocolytics, toco means contraction, lytic means lysis. So this is like you're breaking down the contraction, okay? Toco, contraction, lysis, breaking down. So breaking down a contraction. So drugs are to stop the contractions because you don't want this contraction to continue. You don't want the baby to be delivered too early. You want to buy some time for the lungs to mature, for the steroids to work. So if you have Pprom before 28 weeks, you admit the woman, explain to this woman that this is a case of threatening miscarriage, okay, and the draining can either stop or it can continue. The pregnancy can be lost or it may continue, okay? So you just need to admit them, give them antibiotics, cancel them. There are no role for steroids in here. But the best, of course, in this one, this is just an abortion, so it's termination of pregnancy. Okay, that's the safest. But otherwise, you need to explain to this woman that what they are having now is a threatening miscarriage. And there's a 50-50 chance that the pregnancy will continue or the pregnancy will be lost before 28 weeks. If the woman develops chorioamnionitis, which is one of the commonest complications and what we fear, when a woman develops chorioamnionitis, okay, please, when a woman develops chorioamnionitis, the things that you are going to see, to present with elevated maternal pulse, the pulse of the mother is elevated. This is one of the earliest signs you see. Maternal fever, okay, the mothers will develop a fever, foul-smelling vaginal discharge, elevated fetal heart rate as well, and there will be a tender and irritable abdomen. When you do abdominal palpation, it will be tender and irritable. Then you know that this woman has developed chorioamnionitis. How do you treat that chorioamnionitis, which is an infection, usually a bacterial infection? Treatment is antibiotics cover. Put them on antibiotics and you deliver this woman regardless of the gestational age. If it's at 28 weeks, if it's at 29 weeks, it's 30, 34, 36, you have to deliver this woman regardless of the gestational age because of those complications we talked about. Okay, they may end up with DIC, they may end up with sepsis. The woman may end up with sepsis, end up with DIC. The infection may spread. The fetus may die. So deliver regardless of the gestational age. You need to aim for vaginal delivery in chorioamnionitis. Why? Because if a woman develops chorioamnionitis, the infection is affecting the placenta. The infection is affecting the membranes. The infection is affecting the amniotic fluid. Now, if you deliver via C-section, you only do it if it is indicated, if you can't deliver vaginally. Why? Because C-section will carry a high risk of DIC, high risk of peritonitis and sepsis. Because once you open the abdomen to do a Caesar, you rupture the membranes. Where does that amniotic fluid usually go? It may drain. Some of it may sprinkle or may drain into the peritoneum. And because of that, that's you opening where there's an infection, you form a wound there. Okay, and the amniotic fluid will be all over that wound. The amniotic fluid will be all over the peritoneal cavity. You risk this woman developing sepsis. You risk this woman developing peritonitis. So you aim for vaginal delivery. And if you are going to do a cesarean section delivery, antibiotics are supposed to be given before, okay, the surgery is started. And if you, during your operation, you operate for more than an hour, you may need to also administer another course of antibiotics there. Okay, and when you are operating, you need to, after operation, you wash the, you pack the abdomen, you pack both sides, you pack the abdomen with some gauze. Okay, you pack the abdomen with abdominal swabs. Okay, so that you avoid, make sure by all means to avoid that amniotic fluid from going into the peritoneal cavity. Okay, the abdominal cavity, to avoid infection spread. And you may need afterwards, you need to wash. You wash with warm saline. You wash the abdomen with warm saline. Okay, so that you don't leave out any infection. Otherwise, aim for vaginal delivery. Only do a cesarean section on chorioamnionitis if vaginal delivery is contraindicated. Okay, this is where we end. Thank you very much for your attention. I hope the meeting, I hope you've learned one or two things. I hope the meeting was helpful, and I hope you enjoyed it. If you want more of this content, please subscribe. Okay, please subscribe, hit the like button, and share with your friends, so that the next time that I post another video, another interesting video, you may not miss out on this particular interesting content. With that being said, thank you very much for your attention. Thank you very much for listening. May God bless you. Shalom. Until next time. Bye-bye.